A baby boy was born in Austria on the 20th of April 1889 into humble beginnings, but he was to grow up to usurp tremendous power and to stamp his indelible mark on world history. In 1923, at the age of 43, he developed a tremor of his left hand, and a year later he had difficulty swinging his left arm when he walked. The remorseless progression of his symptoms paralleled his relentless rise to power. And as his authority over his country grew, he gradually accumulated more symptoms. Those symptoms included a stony facial expression, a stooped posture, a short-stepped gait, a tremor of his hand that looked as if he was rolling a pill, slow movements, and a small handwriting called micrographia. To hide his tremor, he tended to position his left hand against his waist, or to grip his belt, or to handle objects such as his glove or a rolled up paper. The man's name, as you might have guessed, was Adolf Hitler, and he was manifesting the classical symptoms of Parkinson's disease. Hello and welcome to this episode of the Neurology Lounge podcast titled Whiteout, When the Brain Loses Its Black Stuff. I'm Ibrahim Imam, and in this edition we will start our exploration of Parkinson's disease. We will begin with a review of its clinical manifestations. The portrayal of Adolf Hitler I just narrated is from the book titled Carrying the Black Bag, written by neurologist Tom Hutton, who concluded that Hitler indeed suffered from Parkinson's disease. Although retrospective diagnosis of historical figures such as Hitler is a scintillating hobby, it is frowned upon in many quarters. This is because it can be wrong. But in this case, Hutton provided strong evidence to show that Hitler's own doctors diagnosed him with Parkinson's disease, although they did it secretly, understandably. Hutton went on to speculate about how the disease impacted the decisions Hitler made as the Third Reich rose and then crumbled in ruins. For example, Hutton wrote that Hitler's perception of failing health and his perception of diminishing vigor, as well as his belief that he did not have long to live, were strong incentives to hasten the timetable for Operation Barbarossa. That was the ill-fated and, in Hutton's words, ill-timed attack on the Soviet Union in 1941. Hutton maintained that Hitler's health concerns and egomania played important roles in his decision to launch this early attack on the Soviet Union. Hutton also believed that Hitler's mental inflexibility, his difficulty in shifting his thoughts, and his diminished executive function, symptoms that can all result from Parkinson's disease, contributed to his poor military judgments. Whether the course of history would have been different if Hitler didn't have Parkinson's disease, or if it was treatable then, remains an open and perhaps disturbing question. The symptoms that Hitler displayed were so classical of Parkinson's disease that they may have been a photocopy of the first description documented by James Parkinson. In his now classical paper titled On the Shaking Palsy, James Parkinson described the key features of his disorder as follows: involuntary tremulous motions with lessened muscular power in parts not in action and even when supported, a propensity to bend the trunk forwards and to pass from a walking to a running pace, and the senses and intellect being uninjured. The understanding of Parkinson's disease has, of course, advanced significantly since then, and as we shall discuss later, we now know that tremors are not a necessary symptom of the disease, and the senses and intellect are definitely not spared by the ravages of Parkinson's disease. We do not have to go as far back in history to the Second World War to get detailed depictions of the devastation that Parkinson's disease inflicts on its victims. One such recent vivid account is by the cardiologist Thomas Graboys, in his memoir titled Life in the Balance. Grabois wrote about how Parkinson's chips away bit by bit at your humanity and at the sense of normality that all seriously ill patients crave. He narrated the onset of his illness to a resting tremor of his hand, which was followed shortly by development of an expressionless face and then a shuffling of his gait. He also painted a picture of the stooped and stiff posture that his body adopted, which he said frequently made him hunkered down, head bowed, and shoulders slumped. Grabois regretted that this global rigidity transformed his once fluid body and once graceful gait into an old man's shuffle. Grabois also described how he became trapped in a body that no longer fully responds to my will. He conveyed this sense of confinement when he wrote of frequently waking up in the morning entombed in his body. And this will be the case until what he said was the paralysis of mind and body passes. Grabois also portrayed how Parkinson's disease impaired his normal daily activities, saying most routine tasks, such as the simple act of dressing, demanded a high degree of attentiveness and concentration. What we have discussed so far are the defining motor symptoms of Parkinson's disease. These are resting tremor, slow movements, also technically called bradykinesia, an impairment of posture and of gait. Later in the course of the disease, other motor features develop, such as freezing of gait, people becoming stuck in one place, and dyskinesias. Dyskinesias are abnormal movements that are often the adverse effects of the medications used to treat the disease. Just as with many neurodegenerative disorders of the brain, the earliest symptoms of Parkinson's disease are subtle and often non-motor. These early so-called premotor symptoms of Parkinson's disease are some of the most diverse for any single neurological disorder. They include the impairment of the sense of smell, excessive daytime sleepiness, apathy, depression, hallucinations, and even a change in the personality. As the disease advances into the later stages, other non-motor features can set in, and these range from psychiatric to autonomic problems, from cognitive to sleep difficulties. After the nature of the disease has been confirmed and the diagnosis established, the search for a cause remains a core undertaking of the diagnostic process. And this is the case even if the diagnosis is retrospective, as in Hitler's case. Some have argued that Hitler had post-encephalitic Parkinson's disease. One of the reasons they advance for this attribution is that Hitler lived at a time when encephalitis lethargica, also known as von Economo's disease, was most prevalent. One argument that supporters of this view advance is that Hitler also manifested autonomic symptoms and, we all know, a propensity to very easily lose his temper. They argue that these features are more characteristic of post-encephalitic than of conventional Parkinson's disease. Many others, however, dismiss this, arguing that what Hitler had was straightforward, idiopathic Parkinson's disease. This is a view I favor myself, and one of the main features of idiopathic Parkinson's disease is this tendency to start on one side and be worse there. It probably doesn't matter whether we can resolve the cause of Hitler's Parkinson's disease, but for contemporary neurologists managing living patients, getting to the cause of the disease may have huge implications. And the long list of potential causes of Parkinson's disease makes this an essential undertaking. Let's explore this with another intriguing story. In July 1982, a man named George Carrillo began to hallucinate strangely, and he woke up next day feeling as if his body had turned into stone. He felt as if everything he did that day happened in slow motion. By the fourth day, Carrillo could hardly move his arms, and by the sixth day, he could not talk. He finally became absolutely frozen. Around the same time, a woman named Connie Sains reported that she felt tired, then stiff, then rigid, as if some evil spell was slowly engaging her in her body. Her sister later found her lying completely immobile, with her eyes wide open, unable to respond or talk. By the third day, her face had lost all expression, and she now looked like a mask. Her body had become twisted and contorted and underwent sudden jerks. By the 10th day, that's how rapidly it happened, Sains looked more like a marble sculpture than a living woman. The gripping stories of Carrillo, Sains, and 6 others were narrated in the book titled The Case of the Frozen Addicts by John Palfreyman and William Langston. Langston is the neurologist who diagnosed and managed the frozen addicts. They had all developed an acquired form of Parkinson's disease caused by consuming heroin that had been contaminated by a chemical called MPTP. You don't want to know the full meaning. We will be returning to MPTP and the model of Parkinson's disease that it led to in a future podcast. It is important to understand, however, that quite unlike the 7 frozen addicts, the vast majority of people with Parkinson's disease have no established acquired cause, and these are said to have idiopathic Parkinson's disease. They may, however, have one or more acquired neurological risk factors, and these include traumatic brain injury, a rapid eye movement sleep behavior disorder, and giant gaps in the brain called Verco-Robin spaces. And there are also a variety of systemic non-neurological risk factors to consider, such as exposure to pesticides, welding, infections, and lifestyle habits too extensive to explore in this podcast. Luckily, there are also protective risk factors, and I recommend coffee, a high vitamin E diet, and physical exercise, but I do not encourage smoking. The observant listener will have noticed that I have so far used the word acquired in relation to the causes and risk factors of Parkinson's disease. This therefore implies that there are also separate hereditary causes and risk factors that can contribute to the emergence of the disorder. Let us explore this again with a fascinating story. That is the story of 48-year-old David, who was diagnosed with Parkinson's disease in 1985 by Dr. Larry Golb. David sadly drowned in a swimming pool shortly after his diagnosis, and when his brain was examined at autopsy, it did show typical changes of Parkinson's. All straightforward so far. The story, however, took a turn for the curious when David's brother, Frank, suspected that he also had Parkinson's disease. Naturally, he consulted Dr. Golb, who confirmed that Frank, like his brother before him, also had the disease. Intrigued by this familial Parkinson's disease, Golb inquired and discovered that David and Frank's family had roots in Contursi, Italy, and that they had 6 other relatives who had also recently had classical symptoms of Parkinson's disease. The story then took a further implausible turn when Golb diagnosed a seemingly unrelated woman named Joyce with the same disorder. Yes, you guessed correctly. Joyce also happened to have roots in Contursi. This creeping Contursi link led Golb to collaborate with Italian doctor Giuseppe Di Iorio. And what they unearthed was that David, Frank, and Joyce were part of the same lineage in which 61 recent descendants had developed Parkinson's disease. The Contursi kindred thereby became the first ever confirmed case of inherited Parkinson's disease. David's story illustrates the way one individual can open a genetic can of worms and also how a single genetic mutation can manifest with such a devastating and elaborate disease as Parkinson's. The Contursi inherited Parkinson's disease has since been linked to a mutation in a gene on chromosome 4. The gene, called the SCNA gene, is now known to code for a protein called synuclein. As we shall soon discuss, this is the protein that is at the core of the pathology of Parkinson's disease, because when it becomes misfolded, it can be deposited in the brain in the form of what are now called Lewy bodies. SCNA-related Parkinson's disease is also called PARK1, P-A-R-K-1, Parkinson's disease. But it is not the only player in the genetic field. Other genes have since been discovered, and these include LRRK2 or LAC2 gene, which is the only genetic form that is clinically indistinguishable from typical Parkinson's disease. At my last count, the list of ever-expanding PARK genes is 23. The menagerie of Parkinson's disease is clearly mushrooming into a zoo. We have so far seen how nature and nurture can act singly or together to result in the same disease. But what are these disorders doing to the brain to lead to the disease? Where is the action taking place? What is the pathology? And what is the chemical impairment that leads to the disease? Well, the playpen of Parkinson's disease is a part of the brain called the substantia nigra. For those who remember their Latin, that means black substance. The work of the cells of this structure, one on each half of the midbrain, is to produce dopamine and to deliver dopamine to a part of the brain called the corpus striatum. It does this through what are called nigrostriatal fibers. However, for whatever acquired or genetic reason, the cells of the substantia nigra fail in this simple task. They degenerate and they lose their shiny black luster and become as pale as ghost. The substantia nigra literally whites out. Without its critical supply of dopamine, the corpus striatum inevitably becomes ineffective in its job, that of making movements smooth. The result is Parkinson's disease. Why do the acquired and genetic predators we have so far reviewed selectively target the dopamine-producing cells of the substantia nigra? Why do they destroy them? This question remains unresolved, but the conventional culprit has for long been the accumulation of the misfolded form of alpha-synuclein. Its cousin, called beta-amyloid, is the presumed villain in Alzheimer's disease, presumed to work in a similar mechanism. Alpha-synuclein deposition, which, as we said, is evident as Lewy bodies, presumably disrupts the cellular function of the nigrostriatal cells. This leads to dopamine deficiency, and this leads to Parkinson's disease. QED, one might say. But this is too picture perfect for the brain. The story of alpha-synuclein deposition causing dopamine deficiency is coming up against a lot of challenges. I will need help to explore this further, and for this reason I will be speaking to Professor Alberto Espe, co-author of the book titled Brain Fables. This will be in the next episode of the Neurology Lounge podcast. Thank you so much for listening or watching this podcast, as the case may be, as we explored Parkinson's disease. I've relied on a few sources for this podcast. One is an article called Adolf Hitler and His Parkinsonism by Bhattacharya. Another is James Parkinson, the man behind shaking palsy by Lewis. I've also used Brainstorms by John Palfreyman, an interesting book. And of course, The Case of the Frozen Addicts by Palfreyman and Langston. If you found this podcast enlightening, why not consider having a look at my book titled Surfing the Brain, where I explored neurology in a similar way as today. You may also want to subscribe to Neuro Checklist, the database if you want a bit more on the clinical dimensions of Parkinson's disease. And to make sure you don't miss the next episode of the Neurology Lounge podcast, why not subscribe to the iTunes, Spotify, or YouTube channels of the podcast? Thank you very much for your time.